talk about these millions of patients who should be treated now with radiosurgery are not getting it. Places like Pakistan and India, the patients are all around the world and they're not being adequately treated. And my ambition in life at this stage is to make sure all these patients can be treated optimally.
Hello and welcome everyone. This is Dr. Amir Khan, your host for Khan Klinics, powered by American Muslim Today. Today we're very excited. We have a renowned guest speaker, Dr. John R. Adler. He's a neurosurgeon and a trailblazer in the medical innovation field. He's best known for developing the CyberKnife and the ZAP-X system, revolutionary radiosurgery with his pioneering work. His recent research publications highlight advancements in non-invasive treatment, focusing on optimizing the CyberKnife for precision in treating brain, spine, and body tumors. This includes exploring fractioned radiosurgery to minimize the side effects and enhance treatment for complex non-spherical tumor.
Dr. Adler was born in New York, graduated from Harvard Medical School,
and completed his neurosurgical residency at MassU in 1987. This was followed by radiosurgery's fellowship at the Karolinska Institute in Sweden with Professor Lars, a pioneer in stereotactical radiosurgery. Dr. Adler, welcome to the show. So Dr. Adler, we're going to highlight what's the importance and significance of this for our non-medical viewers. Why neurosurgery?
I don't really have a great answer. I knew I was a surgeon by inclination and never conceived of doing something that wasn't a surgical bent. I was intimidated by the training expectations in neurosurgery, being arguably the longest in all of medicine. So I kind of put off a decision for many years, even though I was deeply intrigued by the brain and what might be the future of mental medicine. And it was only after I decided that there was no other right specialty for me in surgery other than neurosurgery that I bit the bullet, the opportunity arose, and I entered neurosurgery residency.
Excellent. And how was your experience at Mass General? Was it like, you enjoyed the experience? Was it a tough experience? What sort of message would you say, hey, for doctors and physicians who would want to go into this field, how was your experience there?
It was very arduous. It was an exercise in endurance, and it was definitely one of the toughest things I've done in my life before I started companies. But I did that deliberately. I wanted to challenge myself, and nowadays there's a lot of discussion about self-care and having work-life balance and all that kind of stuff. And I was the antithesis to that. I wanted all in. I wanted to see what it was like to challenge myself to the greatest extent possible. I wanted to go to Navy SEAL training down in San Diego, see what I was made of. And my residency pretty much tested most of that, yes.
Excellent. And then you had the unique opportunity to go to, of all these places, Sweden, and get an opportunity to work in a very specific niche field. How did that came about?
Largely through serendipity. Because of a quirk in my training schedule and the way I joined the program, I needed to do an extra year of research. And I was given license to go wherever I wanted. Again, serendipity, I'd worked with the former chair of neurosurgery at the Karolinska Institute. And I, at that point, had two children. One was in the way, and I needed to be in some location in the world where I thought we'd have the proper family support. And of course, Sweden always is considered very family friendly. So now that little bit of thinking and the determination to go to Sweden to do cerebral vascular surgery, I went to Stockholm. And once I was there, that I became enchanted with Professor Lars Lexell and then pivoted my career almost 180 degrees.
Tell us your experience in Sweden. How was that? And what different expertise did you bring in?
Well, I was very committed to being a superior microsurgeon, a brain microsurgeon, and that was my ambition, going to Stockholm. But once I was there, I realized that eventually microsurgery changed forever by this field of radiosurgery. Medicine, or surgery specifically, has seen almost 100 years of humanity making ever bit more complex, ever bit bigger and bigger and bigger operations, enabled by anesthesia and modern transfusion techniques and antibiotics and everything that we have enabled the modern world of surgery. And yet I realize now that the pendulum was starting to swing back to smaller and smaller surgery. And we've seen that over the last 30 years with, more and more endoscopic surgery and minimally invasive procedures. But radiosurgery is the ultimate in minimally invasive, being utterly non-invasive. I was enchanted by the notion that one could replace big complex operations, not just with minimally invasive procedures, but a non-invasive procedure. And that for me was just too cool to be true. And I just couldn't get out of my head. I decided that radiosurgery was the future of much of medicine, much of the future of surgery, and I wanted to be part of that future. I didn't want to be a relic doing something someday people thought was antiquated, like Civil War surgeons had no idea of asepsis and used to spread infections from patient to patient, and all they could really do was saw off legs. I didn't want to do that. I wanted to be part of what I thought the future of medicine was for centuries to come. And I believe radiosurgery is part of that.
Dr. Adler, then your biggest innovation came about that had changed.
Essentially, the face of surgery and future medicine, and that is CyberKnife. Would you like to explain a little bit to our audience? First of all, how did that come about? CyberKnife, the technology, where did that first innovation came to your mind that I got to produce that, and how did that then subsequently evolve into coming into existence?
Well, I think the audience needs to hear, for starters, what radiosurgery is. And so I liken radiosurgery to what a magnifying glass is to sunlight. The sun by itself, has some effects, changes the skin tone, for example. And it can even burn your skin if you're out for the better part of a day and you have my skin complexion. But if you put a magnifying glass in front of the sunlight, you can transform that energy and, start a fire and do some, incredibly intense things. So with radiosurgery machines, we do the same thing. We take penetrating radiation that can be used to kind of treat the body, but we transform it by focusing all the beamlets of radiation on a point in space. And by doing that, we can concentrate the radiation, and we have something that can literally remove a tumor, kills a tumor inside the human body. And that's what Lexell created when he developed his invention, the Gamma knife. Now, the Gamma knife, already I could see, 35 years ago, was an amazing tool, but it required to identify where the target is inside the head, the brain, a frame screwed into the skull. And that frame provided a frame of reference for then targeting the radiation. Well, that concept wasn't going to work for the rest of the body, and I became intrigued by the idea that if radiosurgery worked well in the brain, why couldn't we do it anywhere in the body? And that question led to a next generation means of targeting, what we refer to today as now image-guided targeting. And the concept that I came up with was image-to-image correlation using real-time X-rays and what we call digital reconstructive radiographs made from the prior CT scan. And now with modern software and algorithms, we can very rapidly compare literally tens of thousands of images and know where the patient's positioned in space. And once you know where the patient's positioned in space, you can now make sure that your sharp beam of radiation always hits the target from many, many directions, and thereby concentrating the radiation the way the magnifying glass does. So the Gamma knife worked in the brain. My goal with the CyberKnife was to make a technology that worked anywhere in the body. And that's what's happened ever since.
Brilliant. CyberKnife then got FDA approval in 1990. And then later on, I think in 94, it was started to already make headlines around the world, especially in USA first. Initially, people were a little bit skeptical about it, but then subsequently an increased amount of interest grew into it. Likely because of the results that they were seeing. The results were essentially equivalent to whether you open up someone or you don't open up someone. How did you find that phase when there were a lot of people questioning the validity of CyberKnife?
Well, when people are questioning you, you're probably on the right path because you're threatening somebody. And I didn't mean threatening in an evil way, but threatening the perceived value and ego and technical skills of many surgeons who over the years have developed a skill set that enables them to do some pretty cool things in the operating room. But having said that, patients almost routinely would much rather have the same outcome with a non-invasive painless procedure. And that's a threat to some people's livelihood. So the fact that I was getting resistance didn't mean too much to me. I also got resistance from radiation oncology. In fact, all I ever got was resistance. I think it's unthinkable that you're going to find new ideas or readily embraced right out of the gate. And I like to quote Gandhi, who famously said, first they ignore you, then they laugh at you, then they fight you, and then you win. And that's really kind of how human progress happens. Whenever there's change, there's going to be people who resist those changes. And while they always argue for tangential reasons that, they're concerned about patient well-being or that's usually the argument, the counter argument. Ultimately, if you dig deep enough, they're really concerned about their own well-being. And so I had to just, over the years, very methodically produce the data to show that CyberKnife radiosurgery was the equivalent, if not better, than open surgery. And eventually, when that data was out, patients voted with their feet. Patients really, really like radiosurgery. And if all patients were always given the option between radiosurgery and microsurgery, you would find very few patients ever choose microsurgery. Even to this day, there's still lots and lots and lots of resistance. And it's always said it's couched in medical technical terms and outcome data and statistical probability, when in the end, no, it's only about self-preservation on the part of the doctors who still resist. But having said that, we treat millions of patients now, and I think the data speaks for itself.
It definitely does. And you'll be surprised to know, you mentioned Gandhi in just your quote a few minutes ago. And we in the audience have a person who's actually in Lahore, Pakistan. And he's saying, CyberKnife is there in their hospital. And it's amazing that you're Atlantic across the world, remotely, where good and benefit is being done to patients from your invention. So you're going to get a lot of blessings there for people who are being treated.
Thank you. Well, yeah, it feels good to know that as we're talking here, probably dozens, if not 100 patients all over the world are getting their CyberKnife treatment right now.
It became very, very important for a couple of reasons. One is that you were able to get to lesions where normally a hand would not be able to get to. So that being one of the unique perspectives about CyberKnife, and this is for the audience. And then the second bit was that it was very, very targeted. A target therapy to a tumor that may be 0.5 centimeters, a centimeter more or even less. So such small tumors being killed with precision from outside the body is amazing. What new innovations are you seeing, Dr. Adler, with CyberKnife is the first question, and then we have a couple of follow-up questions with this.
One of these things happens as fast as I would like to see, but more and more the principle of CyberKnife radiosurgery replacing surgery
is increasingly being accepted, and it also replaces a lot of radiotherapy. I mean, the biggest impediments are not clinical evidence, they're not patient outcomes. It's usually the structure, the financial structures in the world today. Hospitals don't make as much with a CyberKnife treatment as they may make with a big open operation or standard radiotherapy.
Very interesting point.
It's about the money. Unfortunately, as I like to say, follow the money. But the good news is that the outcomes are excellent and they're getting better all the time. And now there's increasing interest in not just treating tumors and cancer, but making lesions in the body to change the function of the body. And the biggest one right now is to treat cardiac arrhythmias. So you can actually destroy the part of the heart that's causing arrhythmic behavior of the heart, and non-invasively you can fix very complex, dangerous, and even fatal diseases like ventricular tachycardia and atrial arrhythmias.
That's really amazing. One can imagine that it's getting to parts of the body that we never thought we'd get there comfortably. You're comparing, Dr. Adler, and when you mention, interestingly, that surgery costs more than CyberKnife surgery, we call it CyberKnife treatment or CyberKnife surgery. Open surgery costs much more and helps hospitals make more money versus CyberKnife treatment, which can be done even as outpatient. So there is a difference there. Is that right?
Oh, these are big financial differences. And the practical reality is that hospitals who run a successful CyberKnife program make a lot of profit. So that's good. But then you can find that 4 or 5 people running a CyberKnife can deliver the equivalent of what, 100 people can do running operating rooms. And so there's an efficiency there. And the way reimbursement works in America, it's the government. Medicare doesn't pay for outcomes. They pay for the complexity and the inputs of the procedure. So if you take someone to the operating room and you open their head and skull and from the top and the bottom, you can charge hundreds of thousands of dollars and get paid for it. With a CyberKnife, you might just pay $15,000. So that's the peculiarities in the U.S. healthcare system, and it really does impede progress. Somebody out there thinks that it's a good thing that maybe they're protecting patients, but they're really not. The opposite. They're impairing by skewing the economic rewards for therapy. You end up getting sometimes the wrong therapies and not enough of the right therapies.
What would you say, Dr. Adler, would be the future scope for CyberKnife, considering CyberKnife has a little limitation in tumor size, and treating out bigger lesions has been a little bit more challenging than treating smaller lesions? Do you anticipate or see changes coming about in CyberKnife in addressing those issues?
Yes, I think radiosurgery can incrementally get better treating bigger lesions, but intrinsically, it's always going to be a little limited. Its success rate and the complication rate is so good with small lesions that it's just undeniable. So my view is that the world is making earlier diagnosis more the norm, and with the earlier diagnosis, the challenge is treating small and smaller tumors, and that's really the sweet spot of what the CyberKnife is designed for. And as long, there were probably always going to be some patients who present with very large tumors, and we're talking about tumors that are 3-4 inches in diameter. And you're right, the CyberKnife is generally speaking a second or third tier option for those patients, and you're still going to need some surgeons to do open operations to remove these biggest of tumors. I think we need the world of medicine needs all these technologies. But more and more over time, patients will be optimal candidates for CyberKnife radiosurgery and less optimal for open surgery.
The invention of ZAP-X gyroscopic radiosurgery helped eliminate some of the costs that were associated with radiosurgery. Would you explain our audience a little bit more about that?
So, you've been hearing how I've spent now 35 years in the radiosurgery world trying to make radiosurgery, expand the indication for radiosurgery, treating new patients, and have met with, reasonable amount of success, having treated millions of patients. But when we step back and look at what we've accomplished and what we think we should be accomplishing, we're reaching today less than 1 in 10 patients who would benefit from radiosurgery. And it may be as little as 1 in 20 patients. So here we have, I've been telling you, this miracle in medicine, and yet we're not treating the vast, vast majority of patients. And so I got a little discouraged. I've been working hard as I possibly can, and yet these ideas just don't seem to be reaching as many patients as I believe they should. And so more than 10 years ago, 12, 14 years ago, I decided to see if I could remedy some of this situation. Some things are almost impossible to fix, like the reimbursement. These reimbursement is baked into government bureaucracies, and it's very hard to change. And over time, I'm sure over decades it'll change, but I can't change. It's much easier to invent new technologies and to cure disease than it is to get governments to move. But my goal was to sort of make a technology that overcame some of the impediments to the greater availability of radiosurgery and to make it possible to treat more patients in more places. And so this time to address the problems at hand, I decided to just go back to the brain and head and neck, where I pointed out we're treating less than 1 in 10 patients. And so I made it. The goal was to make something that was easier to use, easier to cite, and lower cost and less complex. And that was those ideas, that problem, or the ambition, was the genesis for what became the ZAP-X and my company ZAP Surgical, which makes the ZAP-X.
Dr. Adler, your work has been now explored in the field of epilepsy patients. And you wrote a paper regarding that in 2017. How is radiosurgical treatment of epilepsy? Tell us a little bit about that. How is that going about now? It's very exciting for a lot of the patients I know when we have now radiation or radiotherapy being treated for resistant epileptic patients or non-resistant for symptomatic relief.
Well, it's not entirely a totally new idea. We observe now for several decades, going back to Professor Lexell, that, and some of the work I did with him, is that patients who had seizures from lesions in the brain, like AVM, arterial venous malformations, often had improvement in their seizures literally within a few days or weeks of the treatment. And radiation somehow seemed to fix seizures in these patients. And doctors have gone on to treat seizures in a number of other epilepsy patients. And with some success, there was something called mesotemporal sclerosis, which is a condition that causes a very common type of epilepsy called temporal lobe epilepsy. And some doctors, headed by a team at UCSF, try to replicate what you did with an open operation instead of actually removing the whole temporal lobe, as is done with the traditional seizure operation. They tried to just burn it with radiation. And they showed that you could get the same effect with radiosurgery, albeit that had a fair bit of temporary complications. But whatever, you see that people have been trying to treat epilepsy over the years, and that there was definitely a role for radiosurgery. But what I would call seminal observation is that it is, in my experience, radiation can change the function of brain without killing it. So historically, all radiation, if we think about the way people viewed radiation for 100 years, radiation kills stuff. You use radiation and you kill tumor, you kill the brain, you kill the liver. Radiation kills stuff. Well, what we've learned in treating things like epilepsy is that there's a dose threshold where you don't kill, but you can change the activity of the brain circuit. And this has been a very important observation, and we're referring to this as radiomodulation. And radiomodulation is a concept that feeds off the notion of neuromodulation. So one of the biggest themes in medicine, and really one of the biggest unmet needs, is the idea that we do not know how to treat behavioral diseases very well. There are diseases like addiction, depression, chronic pain, for which medicine has failed these patients horribly. The World Health Organization will tell you things like cancer, HIV, tuberculosis, heart disease, they're really relatively unimportant, thinking the big picture, compared to behavioral diseases like obsessive compulsive disease. And so what you found is that drugs just aren't working anymore. They don't work very well. And if you don't think they don't work any well, just walk on the streets of San Francisco or Los Angeles, and you'll see how many patients with mental illness there are who are or drug addicted. We just don't know how. We don't have good treatments for much of the world today who suffer from behavioral diseases. And so the theme behind neuromodulation is that we're not going to treat these patients with drugs. We're going to try treating them with procedures that can change the electrical activity that's causing this disease in the first place. So these diseases, depression, addiction, obsessive compulsion, they're not diseases of the brain, they're diseases of brain circuits. And so neuromodulation theme is to change these circuits primarily with embedded electrodes in the brain, and giving off jolts of electricity and altering the activity of the brain circuit. And it just works. We've seen the cases of Parkinson's disease where patients 1 minute are trembling like crazy and the next minute have nice smooth movements. So we've taken the premise of radiomodulation to see if we can't replace what we've done with deep brain stimulation with a non-invasive, painless, cost-effective procedure. And that's very much what we're doing now in the future. Now, most of our work here at ZAP Surgical has been in animal models, but we're just about to start embarking on human trials, both in Europe and in China.
Again, fascinating, because think about where you start from, and now you've gone to treat psychiatric disorders, OCD, you're looking out for mental health disorders. and how are they gonna be impacted by radiosurgery? One of the questions, Dr. Adler, that comes across from the audience very frequently is, what's your plans and how are you thinking of integrating AI in neurosurgery just general? What do you see the role? And the important part would be, you have done some work already on AI with particularly radiosurgical techniques. Explain to us, would you mind please, about what do you see the AI role and integration in radiosurgery from planning to outcome?
Well, I mean, AI is a tool, and it's a tool that will touch.
All the things I do in many different dimensions. It doesn't totally change everything, but it provides us an ability to incrementally improve what we do today. So, for example, in the world of treatment planning, we have to take this beam of radiation and paint it over the target region so that we can most effectively concentrate the radiation in the tumor and minimally irradiate the surrounding normal brain. Well, we've been using AI-like solutions now for decades to do a better job of concentrating the radiation. And as AI gets better, we can do a better job of concentrating the radiation. The ZAP-X uses AI tools to do a better job of more accurately targeting. How do we know more accurately where the patient's head is in space, and so that we can more accurately get just the region? Again, we're talking about tolerances of 0.1, 0.3, 0.4 millimeters here. So very, very small. You're talking, 200-300 microns. So these are small little regions that we're trying to reach every bit more accurately, and AI is a tool there. And then lastly, in this world of neuromodulation, functional world, treating psychiatric diseases, there's some very good work, especially by my former mentee, Eddie Chang at the University of California, San Francisco, who have shown that by using ever bit more sensing of the electrical sensing of brain function and AI tools, you could do a better and better job of deciding where the problem is in patients like depression. And once you know where the problem is, then the tools that I'm describing for neuromodulation, radiomodulation, can do an ever better job of treating diseases like depression. So I think, yes, you'll see AI everywhere, but by itself, it doesn't solve the problems. It just helps what we do it better.
We appreciate that response. We really appreciate your global health accessibility work, where we've just discussed briefly before how you have integrated ZAP-X to affect the cost that is associated traditionally with radiosurgery. So just a general, another thank for the grand work you are doing in that field. It really touches a lot of people, and your part of contribution to that is really appreciated. I don't know if you want to say a word about it or two, but I just wanted to make sure that we convey that message to you as well, and you get that message. It's being appreciated at a lot of places. And
well, thank you. I mean, that is my vision, especially with ZAP.
We talk about these millions of patients each year, 5 million or more patients each year who should be treated now with radiosurgery are not getting it. Many, if not the majority of them, are in developing countries and places like Pakistan and India. But China for us is a very big opportunity, but Eastern Europe, Russia, South America, Latin America. So, I mean, the patients are all around the world, and they're not being adequately treated. And my ambition in life at this stage is to make sure all these patients can be treated optimally, which is what I think radiosurgery is.
Truly appreciate that. A final message to our audience. What can we anticipate to see in the next short term and a long term from cyber surgery? We'll be definitely very keenly following the progress and stuff.
Well, the final thought is nothing happens too fast in medicine. I wish it was that easy. If it was like building new cars or websites or something, you could change, you could iterate very fast. So these things happen slowly and unfortunately too slowly. But what you're going to see over the coming years and decades is ever greater accuracy to both shape the radiation inside the target you want to treat and especially hit the target. You'll see it more user-friendly, so more doctors and more locations can treat the more patients that I've alluded to. And gradually, we'll keep expanding the indications. We've been talking here today about things like Alzheimer's, about depression, addiction, things that I think will, in time, become a reality. Alzheimer's is probably the last of all of them. But still, it's a concept that's timeless. And because the non-invasive approach of radiosurgery is what medicine is going to look like, not just the next 10, 20, 50 years, but really over the next 100 years, if not 1,000 years. Radiosurgery is part of this non-invasive directed energy revolution that allows us to reimagine how to reconfigure the human brain and the human body to solve human pathologies.
Dr. Adler, it's a great pleasure having you in our podcast and our studio today. And thank you very much for your precious time today.